So hypoglycemia, this is low blood sugar. Well, this is kind of an interesting thing. How does this happen? Because in diabetes, we don't have enough insulin. And that means that our blood sugar gets high because the insulin takes care of the high sugar. So the only reason to have hypoglycemia in diabetic patients is related to the treatment for diabetes. So either an insulin overdose, so they've given themselves too much insulin, or they've taken normal insulin and they haven't eaten anything. Maybe they threw it up. Maybe they exercise too much. When you exercise, your cells are much more able to take in sugar without insulin. It's kind of cool. Exercising muscle tissue is actually able to take in glucose without the insulin. So if you exercise, you can drop your blood sugar fairly significantly. So if they overdo it and take their normal amount of insulin, and don't eat more to sort of compensate for that, then overexercise can cause hypoglycemia. So let's look at what happens when you're hypoglycemic. So your blood sugar drops. Your brain's not getting enough glucose, so you may have alterations in consciousness. I would say it kind of starts with the unusual behavior, maybe weakness, fatigue, just not feeling good. It can actually lead to seizures and then eventually unconsciousness. Now, at the same time this is happening, the adrenal glands, which are those little glands on top of your kidneys, which release epinephrine or adrenaline, that's how I remember it, adrenaline. It comes from the adrenal glands because it actually says so right there, adrenaline. Release epinephrine. So that's your fight or flight response. That's your body's under stress, so your adrenal glands release this epinephrine. It gives you pale, cool skin. It makes you sweat, that cool sweat. So pale, cool, diaphoretic. These patients become tachycardic. They have increased blood pressure, and they may even feel sick to their stomachs. So pale, cool skin, sweating, nausea, and tachycardia. So sometimes hypoglycemia is actually called insulin shock. But is it really shock? No, they just look shocky because the adrenaline is in their system, and that's the body's response to shock. And so we've kind of in the medical community associated that pale, cool, diaphoretic look with shock, but really it's just associated with this epinephrine, with the adrenaline release. So it's not really shock. The other thing about hypoglycemia, it is possible that it can occur in non-diabetics, and the most common cause is alcohol use on an empty stomach. So remember, a patient is never just drunk. These patients who have alcohol in their system, so check a glucose level on your drunk patients. So what do we do? Well, if the patient is conscious and can maintain their airway, and that's key here, give them sugar orally. So this could be oral glucose. But the oral glucose, honestly, is going to be burned really fast. Their body is just like itching to get this sugar in. So you're going to give them oral glucose, and 20 minutes later, their sugar is going to be low again. So really, we want to give sugar or food. So the oral glucose is kind of tying them over. And then we really want to get food in their system, something like a peanut butter and jelly. Peanut butter and jelly is great. Most people have that stuff in their house. If not, something that has kind of protein and like maybe a little bit of a fat component, and then complex carbs. Glucose itself is actually just a simple carbohydrate. We want to get some more complex carbohydrates in that are actually going to last a little bit for them. The jelly actually is a lot of simple carbs, so that's going to help keep their sugar up for a little bit. The bread and the PBJ is your complex carbs, and the peanut butter is really the protein and the fat component. So it's a pretty good balance for somebody who is in kind of a hypoglycemic crisis. For the unconscious patient, support the ABCs, and then go ahead and get ALS backup for IV glucose. This is something that the ALS providers can actually fix, and a lot of these patients don't end up even going to the hospital. So get the ALS backup, give the IV sugar, And in this case, when in doubt, give sugar, as long as the patient can maintain their airway right there. Maintain airway. So ask all diabetics, have you eaten today? Have you taken your medication? Tell me. Tell me more about it. What did you eat? Was it normal for you? What medication do you take? Is it a long-acting insulin? Is it a short-acting insulin? Or is it an oral medication? And what have your blood sugars run? Have you checked your blood sugar today? And again, you know, this says when in doubt, give sugar. So if you need to give them some sugar, give them some sugar. Diabetes, unfortunately, it is a chronic disease, and it carries some complications with it. Turns out the blood vessels don't really like all the sugar. Extra sugar tends to cause some inflammation and inflammatory processes. So it kind of eats away at your blood vessels. It leads to greater risk of myocardial infarction, so heart attack, a CVA or stroke, peripheral vascular disease, so basically it attacks all of your blood vessels. Blindness actually also is a result of vascular issues. Renal failure is another very common complication of diabetes. Oh, and the blindness can also be caused by severe hyperglycemia, so chronic hyperglycemia. The sugar kind of actually gets in the lenses in the eyes and can distort your vision. This can actually be sometimes reversed with the blindness if it's caused just by the hyperglycemia. One big complication of diabetes is diabetic neuropathy. So basically, you stop feeling things. Neuropathy is your nerves stop working. This can lead to a few things. One of the things it can lead to is gangrene. So a diabetic can get a cut on their foot, for example. They don't notice it. They don't notice the fact that it's getting infected and that it's disgusting, and they can't see it. They don't look at the bottom of their foot because they don't ever notice it hurting. So they can end up with gangrene. That's part of the reason a lot of diabetics end up with amputations. The other part is that peripheral vascular disease. So it's very common for diabetics to start by losing toes, and then feet, and then sometimes all the way up to, below the knee or even above the knee amputations because of the vascular disease and the neuropathy. The other problem that diabetics have is this concept of a silent myocardial infarction, a silent MI. So this is a heart attack without any chest pain. The patients will say, I've just kind of got these weird feelings. Something's not feeling right. I feel a little sick to my stomach, just a little bit like I can't catch my breath. And they kind of look sick when you go in. It's certainly possible they could be having an MI. They could be having a heart attack. They just don't feel any chest pain because the nerves don't work. So yeah, silent MI. Oh, here we go. Here's my slide on silent MI. Again, it's acute MI in a diabetic that presents without chest pain. It may resemble the flu. Manage these sick diabetic patients as if they're critically ill until you can prove otherwise. Because they really are. Patients with diabetes very much struggle to heal. Diabetes is a big risk factor, or a big contributor, I guess, to overall mortality from other causes. So if somebody who's a diabetic is in a car accident, for example, it's a lot harder for their body to heal than for somebody else similar to them but without diabetes. And that's it. If you have any questions, please be sure to bring them into class. Thank you.